Good morning. How y'all doing in New York?
Excellent. The weather looks beautiful. Let's see what you have.
Great. So listen, great case today. It's not necessarily in-stent restenosis. It may be a future in-stent restenosis once we cross this long chronic total occlusion. But I'm glad y'all are here to help me out with this. We have a great case. We're broadcasting from North Carolina. I've got Alexis in the room with me, Tina beside me, Justin on the panel outside. But regardless, let me go ahead and take you through this case. This is a 67-year-old gentleman that literally presented to me with almost a rest pain type of syndrome. His toes are discolored. And he has your typical history of high blood pressure, high cholesterol, diabetes, history of heart disease. He does have heart failure. EF's about 30%. But let me show you his angiogram. So his right leg is the focus. And so we access the left common femoral artery, placed an omniflush catheter level of the distal aorta. And then this is what we saw. So as you can see here, his renals are widely patent. His distal aorta looks good. His iliacs are very tortuous, and he tends to move a little bit. So you get a little motion artifact here, but I think you can appreciate the iliacs are widely patent, but they're very tortuous, okay? The second thing is we did a runoff, and as you can see here, again, the iliacs, very tortuous, widely patent. We get down to the common femorals and the profundas, widely patent. SFAs, left lower extremity looks good. The right lower extremity, this is our issue. So above the adductor canal at the level of the distal SFA, it occludes, and it is a hard occlusion with several collaterals. And then he moves some, but it looks like they're tibials here down below. So what I did is I went up and over, understanding that I'm going to come through that left common femoral. I used a thin-walled sheath. I used a radiant sheath. It's 110 centimeters in length. Typically, we use it in the radial, but this thing tracks very nicely and gives you excellent support. So I placed this in, and this is just showing me going up and over. And then what I can show you now is I injected through that sheath. Wow. And I think everyone can see below the knee, all three tibials come back strong, a huge array of collaterals. So this has been there for a while. So then what I did is I went ahead and accessed from below. I think you can appreciate that nice posterior tibial. Again, all three of them look really nice. So this is my micropuncture needle, just showing you me sticking. Then I do it angiographically, and then placed the wire up. I placed a range sheath in from below. It's a 4 French range sheath, 3 French profile, much like a slender, and then took an array of wires. Now, this is a long chronic total occlusion, and the thing is understanding your wires. So I typically start off with an 0.14-inch platform. I start off this with a Mongo. It's a hydrophilic 0.14-inch. It's got a preform. It's not a preform tip. It's got a break in the distal end of the wire, so it will always bend up in the same place. So it will cause a tight J. With this, I started off with a quick cross to support it to see how far I got, and I think you can appreciate this is where I was able to get with the quick cross. And then what I did is I switched out for a chronic total occlusion wire. I started off with a hydrophilic polymer-coated jacket wire, 0.14-inch platform, 18-gram tip. It's a Victory wire made by Boston. Was able to get up a little further, but again, this hard plaque just made it very difficult. Then I chose a V18, which again is a hydrophilic 0.18-inch platform, floppy tip, was able to bend it, loop it up, and then take a Navi Cross, 03 Navi Cross, and give me more support, and made it up a little bit further. And now where I'm at, I've got a 30-gram Estado actually I kept the V18 from below, and now I'm working from above, and I used a 30-gram Estado and went through a similar type of array. So I got up to a certain point from below. Now, as you can see, this is a Navi Cross with the support of this wire, and now I was able to traverse a 30-gram Estado here. Now, I have no idea. I probably have gone subintimal, both from above and below, but I can't tell you that for sure. I'd like to think I stayed true lumen just because I used a larger crossing catheter with a J because it tends to keep you true luminal, but this is very hard plaque. Oh. So this is where we are currently.
Wow.
Any comments right now?
All right, yeah, so we have a very nice panel of surgeons, IR, and interventional cardiologists. And before the surgeons jump up and say, hey, why is this not patient a candidate for surgery, good, distal targets, we'll just go around to the panel and see what their thought process is, their approach. Antegrade, we just continue the same thought process from last case, but anybody would go antegrade first rather than directly going retrograde. Good visualization, good collaterals, good distal.
I would, just because if I'm lucky, I wouldn't have done that for anterior tibial because you have blindly to take the turn. But you can, if you get lucky, you can go straight into the peroneal from above and cross all this lesion. Has happened to me. There are times I have prepped the leg for safari and then somehow I'm into the peroneal artery.
Yeah, I think this is obviously a very tough case, George. Good job. I like to go antegrade first because I think taking a wire down where he is and then ballooning that sublingual tract, then you have your lower profile wires from below that may pop into it. So I definitely try antegrade at least for the first minute and a half, 2 minutes. And then I would have retrograde in this one as well for this type of lesion. But I like to go as far as I got to antegrade as long as I feel like I'm not coming out of the vessel and then balloon it to create a channel.
How about Dr. Genovese?
Yeah, I agree. I have to agree. You have a very small window where you're going to want to pop back into your true lumen below. You're not going to want to mess up your bifurcation trying to re-enter there. So probably try a little bit. Again, I've had the same luck as, I'll happen to pop right into the perineal and true lumen. But any sense that I'm kind of diverting out into a subintimal space, I'm very quick to retrograde here.
Dr. Bauer, you have any thoughts?
I would try antegrade first. And another thing that I prefer to do is using wires like a Stato just to get me through the very tough spots and then exchange it to a different wire. Because a Stato is like a spear. It can literally go anywhere you push it hard. So, and if you fail crossing antegrade, then, the distal vessel, tibial vessels look pretty good. So you can go with retrograde and then try to cross it from below.
So I guess I'll be the lone person to say I would go retrograde first, but the majority of my work is primarily transpedal as it is. So I would attempt to go at this knowing that I'm true lumen from below, which is the most important place to be true lumen, and then work my way back up north. I probably would have, where he got stuck, instead of going to an Estado 30 for the length that he went, I probably would have brought a balloon up, blow it up low inflation to kind of keep me angled towards where the lumen is taking me. But this is a very difficult case with very difficult plaque to cross.
Yeah, you really have to appreciate the chronicity of the vessel, and you have to understand it's like a trifurcation, and the patient has good tibial vessel runoff. So you want to preserve as many tibials as possible, hopefully all three, anterior, posterior, and peroneal. But then that's where we need both by antegrade and retrograde approach.
Yes, I completely agree to this. I would start with both in this because I'm a firm believer in the CTOP classification. If you looked at his angiography before, the convexity and the concavity of the lesions, and the point is, when you're using wires like a Stato and stuff, you can get into subintimal, and the only way you could surely say that if you have another excess coming from below. We know from multiple studies, pedal excess is safe, you can come up, less time, less contrast, less radiation. I would go what George did. I think it's for these cases to prep like this and prepare from the very beginning. To go from below will save time and contrast, and that's what actually happened to him with the Stato when he came down. He was not sure where he is, but having another access from below, it really guided him which way to go. So I would go pedal as well from the start and antegrade and retrograde both.
All right, Dr. George, what are your wires right now in there? Let's see what you're doing, and then we'll go to a first lecture.
All right, so what I'm doing is I've got a Stato 30 gram from above. Let me also point out this too. With the 0.14-inch platforms, a couple tools I have on my deck here. I've got a spinner. Wayne, can you mag up on this for me? So they can see it. So this is a super torquer, right? You hold it like a gun, and you sort of, rotate it back and forth. It rotates the wire 5 revolutions one way, 5 revolutions the other. The importance of this is that it takes off the orthogonal friction of your wire and allows you to go through the chronic total occlusion a lot quicker. So I use that for my, typically with the Victory wire, is where I use that most often. The other things I've got on my deck, you see these, instead of using gauze, Wayne, can you mag up on this? These are swipers. Instead of using gauze, the gauze leave debris on your devices, your wires in particular, just like these green towels, right? They leave debris on there and it goes in there. So I usually like to use these. Now, going back to the case, what I'm going to put in from below, currently, you got that Mongo wire. I'm going to put an 0.14-inch platform Mongo wire. I'm going to take a micro balloon. It's a 3.0, I believe, 120 micro. And then I'm going to take a 4.0 150 Sabre balloon from above. And I'm going to try to work my way down and then do a double balloon technique and try to recanalize this long chronic total occlusion. Awesome. So that's where we are currently. So I'm putting the Mongo back in from below. And I've got a 0.18-inch Estado from above. All
right. So we'll let you work on that.
Again, I heard the...
Go ahead.
Go ahead, I'm sorry.
No, go ahead. We just want to make sure people get along.
I think there's a delay.
Yeah.
So I just wanted to say, with your chronic total occlusion wires, remember that a lot of guys, they're talking about using 30 grams and, and so forth. And when you take a crossing catheter behind it, it increases your gram strength by about 3.5 to 4 times. But what I see commonly used, and I do not typically do this, is bend up a stiff glide wire, right? If you want to go outside the lumen and cause damage, then you use an 0.35-inch platform, in my opinion. Say 0.14-inch, and it allows you to at least feel it, and you make a small puncture, and you have good tactile sensation of the wire. The other thing nice about an 0.14-inch platform is that you can use all the devices on your shelf. When you step up to an 0.18-inch, you lose a third of your devices. When you go to an 0.35-inch, you lose 2/3 of the devices. So I think it's very important to remember that. So most all cases, I'll use an 0.14-inch platform. But that's it. I'm going to keep working.
Yeah, so we're going to put you on the side and we're going to start our first lecture.
So what I've done is I've taken 2 balloons in. I'll be honest with you, my first wire from above got stuck on the balloon, so I had to remove it all. But I put my wire back down there. And then I ballooned with a 3.0 balloon from below and a 4.0 from above. I don't know if y'all saw that. Let me show it to you. All right, so I think you can appreciate I've got a 3.0 below and a 4.0 from above, and I just dotted it back with that 4.0. And then what I did is I took a couple of oblique views just to see. Actually, what I'll do right now is just do that. I'm going to rotate my camera, wire pull back from below.
So just for the panel, being aggressive enough, especially from the anti-grid aspect, would any of you switch over to an 035 system? 014, 018, but 035, anybody has a preference for that? Yes, Dr. Waika.
I've done it several times, but only when I'm above the knee. If I manage to push the wire all the way, and then I'm close to the open lumen in the SFA, I have used Stiff Glide. That's my last resort. I have been successful. If you start it very distally, you can get into dissection or perforate.
All right. Dr. Ansari, how about you? You would take a wire, catheter, glide, loop technique? No? Nobody likes it?
So I have tried it. It's like a last resort thing. I would still change wires of different consistencies, go up to 018 and try harder with the catheter. I have gone up to 035 as well, sometimes even as a last resort using back of some wires. I won't recommend that, but it's more like a last resort technique.
All right. Okay, so I guess we're just switching our wires back in and we balloon. So let's see if you have any pictures.
I want to ask George if you can hear.
Yeah, hold on, I'll show you what we've done.
Right.
All right, I'm going to open up this sheath from below just so it'll get good flow. Look at that. So we've got a connection somewhere.
Correct. So you have nice collateral, good connections, a lot of dissection. Now you have to find the true lumen, connecting from normal to normal or true to true.
George, it looks like right in that mid-patella
That is
region,
correct.
Yeah.
right in that mid-patella, your wires kept tickling each other. Probably not the right medical word, but
Yep, I agree.
Did anywhere
And that's where it showed us, whoever's making that comment,
it's Kumar.
that our oblique showed us that. So what I'm going to do is I'm going to take a corsarium from below.
Yeah, that's one of the
Just
other
so I
techniques
can,
to see if your wire
manipulate.
entangles there and you feel it touch, you're very close. And I think that's the right spot to re-enter or try to connect those two dots by either, re-entry, tearing those intima off, and trying to connect those wires.
I agree. If you want me to work, if y'all want to give another lecture.
So yeah, we'll move on to
or
the next.
otherwise y'all can sit here and watch me. It doesn't matter.
That's a great idea. All right, George. So we see some movement right there.
Yep. So what we've got here, let me just show you this real quick. Let me pull this wire back because it's pushing me off. But what you got here is, I'm going to show you two oblique views. So I'm in the path, no question about it. I think you can see as I go LAO, we're on par. As I go REO, still on par. So except for right there at the distal end. So it looks like I'm going out right here. So what I'm trying to do is I'm trying to get an angled Dave catheter down to that level, and I'm going to externalize the wire. But I may have to take a balloon before I do that because what's happening is my Dave isn't long enough. So I'm trying to get it down there, but having a little difficulty. But once I get the wire close to the catheter, I'll externalize it. And then once I externalize it, I'll be flossing and I'll be able to open this whole thing up and we'll get a better look. So if you want to go to your next talk.
Well, yeah, we'll go to the next talk, but just to get the panel on board. So any other different strategies, any other thought process from the panel?
George, hello? Hey, George, this is Kumar. The only thing I like to do in these is I put a micro snare from below. Whether you have a decent access here from below, but I'll put a 4 millimeter snare because in that subintimal plane, right by the mid-patella where you saw them touch each other, that snare gives you a nice lumen to grab it without a catheter. And often I'll find that's what I would do here.
Right. Okay, great. Dr. Genovese, any thought on, the wires are close. I mean, an important point is to have multiple angulations and exactly on top of it. You're really close. You're not still connecting. Any of you will opt up and not thinking about the cost, talk about doing a re-entry somewhere?
I mean, I think reentry.
Like device?
Can you give me a 5.0 balloon?
Are a good utility. I think you have to be in the right situation. Unfortunately, I don't love using reentry devices when you're just trying to reenter in a different dissection plane. I think that typically doesn't set you up for success, particularly if you've already tried cart and reverse cart. I don't think you're going to get a whole lot more benefit out of it. I think using it on IFU is better. I also think keeping in the back of your mind what this patient's vein mapping is always pretty helpful, knowing when you're going to say that enough is enough and maybe let's think about a bypass.
Right. So I think a good important point here is to keep your dissection plane under control and not try to keep expanding. Of course, you have ballooned it now, so hopefully the two wires will connect. Using different wires, techniques, stiffer wires will probably give them more penetrability and more pushability. And because you're using an 014 system, it just becomes more technically challenging, I guess.
I would have tried get a balloon up in the SFA from below, like a 3 millimeter balloon, inflate it and come from above with an entry device and aim with your needle towards the balloon. And if you break the balloon, then you just put the 014, my work.
Yeah, so that's also one of those techniques you've used in the past where you use to puncture the needle through the Outback or the Pioneer and actually go into the balloon and use the hypotube of the balloon to really connect to a true lumen. And then like Dr. Adams was talking about, to externalize it and work from the top. So I think that's a good idea. All right, George, let's see. I think you break the cap and you look well connected.
Yep. So we have. I've got the wire from above down the anterior tibial, and now I'm just got a 5.0 120 balloon in there, and I'm just opening this up for us.
So you want to tell the audience what did you do different? Like since we left you, what did you do? Anything special maneuver? Any change of wires? Any techniques that made you cross?
Yeah, absolutely. So what we did is, again, we used a double balloon technique, fenestrated the lumen, such that now you got an open lumen between two planes. Then what I did was from above, I took an 18-gram, I switched out for the 18-gram Victory again, and I had trouble finding the true lumen from below. I could tell that I was meeting the wires because they tend to dance with each other. Remember, there was a paper out of MIT that shows that metals have a natural affinity for each other. And so if you can get them close, then they'll crosstalk. We have a problem with this a lot of times in the coronaries, but we like it in the peripheral. So then what I did from above is I took that 18-gram Victory, used the spinner, and was able to just continue to wrap the wire from above and then went straight into the anterior tibial. So, sir, keep your legs still.
Right.
Yeah.
So from the...
So that's where we are now.
Beautiful. So from the balloon perspective, what size balloons did you use to cart it? Like, we just want to know how aggressive or not that aggressive you were. Used a 4.0 or a 5.0 balloon?
For the double balloon technique, I used a 4.0 from above and a 3.0 from below. For this, since I know have met the wires and making the lumen, from the P3 segment of the popliteal back into the distal SFA, I've used a 5.0, and I believe this is a 150 balloon.
Okay. For the panel.
Okay.
Go ahead, Raj.
Go ahead.
So
I'm just going to say I'm going to remove the balloon and take a picture so you can see it.
Beautiful. Yeah, we're seeing you right there. We're still live with you. So just to get the panel in, from your perspective, for balloon sizing, is there a rough math rule you do? Add the two balloons, divide by 2, do a 2/3, or is just random picking the numbers based on the vessel sizing?
So I'm a big proponent of using a lot of ultrasound during my cases, and I do the measurements using ultrasound, and it gives me a really good match of what we should use. I would actually go lesser because the concept over here is just to see that they both match. That would be my technique.
Any other different perspective? Dr. Perugia, what about you?
Yeah, no, I agree. I'm a big user of IVUS and ultrasound to try and get sizes correct, because I'd be concerned coming up with a 3.0 from below if we are oversized, could potentially disrupt the AT.
I agree. So, I know we've crossed it, so I'm sure you're going to balloon it, and Dr. Adams is going to tell us what his thought process of the definitive management is. But in lieu of perspective of all the available stuff, we always have to consider the sizing of the vessel and how it tapers down. And now here we have a trifurcation, essentially, and I'm sure. So let's ask the panel down the lane to see what's their thought process, like what would be the next step in management of this patient, especially the definitive therapy. What are we looking at? DCB, DES, Opera? Nothing, maybe half and half. Coronary stents.
Personally, I think you're going to have to lend a Supera behind the knee. The question is where you're going to start it and stop it. And then I would want an IVUS evaluation of the P3 segment of the pop down into the trifurcation, because you really don't want to lose what was already there, which was excellent 3-vessel runoff.
Dr. Baba, how about you?
Yeah, I totally agree that I was close to the, in the distal popliteal and in the proximal AT and closer to TP trunk will give you a lot of information, and that will be helpful for you to figure out how you want to treat it, see where you are, see what's going on.
Yeah.
And based on the information from IVUS, then you'll come up with...
All right. Dr. Genovese, looking at this picture, here you can see, of course, the dissected popliteal vessel, which most likely will end up stenting, maybe drug coating it in addition. But we want to obviously salvage that AT and the TP trunk going into the posterior tibial. Your thoughts on the approach?
Yeah, I think that this is a really nice opportunity to perform some kissing balloon down in the TP trunk into the P3 segment. I didn't see, because I was talking, I think did he come antegrade from the retrograde from the AT as well? Yes, okay. Yeah. So, if you can come one from above and one from below, but I would definitely perform kissing balloon angioplasty there, preserve the TP trunk and the AT origin.
Yeah, put it on now.
Yeah. So, Dr. Adams, what are you trying to do is just get your balloon down to the anterior tibial, establish some flow? Are you planning to do a bifurcation ballooning down there?
So that's a great question. So I think the important thing here is I didn't open up the ostium of the anterior tibial. So the question is, am I in the same lumen in the TP trunk and the anterior tibial? And I may be. So if that's the case, so you need to be able to recognize that. The other thing that's important is I've got tibial access and I got contralateral retrograde. People keep talking about antegrade. Remember, this is an ad hoc case, okay? Unless I would have switched my access after I took the pictures, because you're seeing the pictures just like I am. So if I would have done that, then I would have had to go to the other side and switch my whole room. So that's the reason I'm still contralateral retrograde. So saying that, and it's hurting me in terms of length. So the thing is, coming from a retrograde approach and a contralateral retrograde approach, if you needed to do a double balloon technique, as Liz said, you can do that. The other thing that's more important than that is remember that if you got to lay scaffolds, the only thing that has shown benefit other than TAC for dissections below the knee in short lesions is coronary drug-eluting stents. And the nice thing is, from this approach, coming from a contralateral retrograde and a tibial approach, you can kiss two stents nicely if you had to. Whereas if you had to come from above, sometimes it's a little bit more difficult. So that's the first thing. In terms of the stenting of the popliteal, absolutely. Sapira probably has the best evidence, the best radial strength, best flexibility. And then when you get above that, if we need another one, I would probably use a drug-eluting stent, just because of the calcium. We'll see how much, you may use two Sapiras, depending on how much calcium you have. But that's my strategy.
Excellent.
What are y'all's thoughts?
Panel, let's go down. How about your thought process? Anything different from him?
No, I totally agree. I think in a perfect world, he can get away with kissing DCBs in the TP trunk and the AT and then a Sapera up. In an imperfect world, he's going to have to do a little bit of Y stenting there. Yeah.
Right, that's true. All right, great. So I think we all agree with your thought process. We'll let you balloon the lesions, get some luminal gain, and get some pictures, and we'll have the last talk. So we'll go one final time back to North Carolina to see where we stand. We see the AT results were looking good, but let George take over.
Both of these wires on it.
George, can you hear us?
Hey guys, can you hear me?
Yes, we can hear you. Go ahead.
Take out your dilator. All right, so what we've got now is I put in a 5 French sheath from below, and I think you can appreciate, hold on one second. So what I did is I took a 50 or a 40-200 Ranger drug-coated balloon from below. I think we're in the true lumen in the TP trunk AT communication. I think it was more spasm than anything. I'm just going to show you this. So this is actually a bunch of loops. That's my injector tubing. But coming up here, so this is the drug-coated balloon I have in place. What I'm going to do is I put in 2 wires, the 035 from above, because I'm going to have to switch out my sheaths because I don't have enough length. So I'm putting a 90 centimeter sheath so I can bury it rather than having 110 in place. So what I did is I trapped my 014 wire, as you can see. And then what I'm going to do is I put an 035 wire in, and I'm putting a 6 French 90 centimeter sheath in. Can you get it or not?
Yeah, all right, great. So did you try to rewire from one tibial to the other just to document? I mean, I know it's probably more of a feel to feel your intraluminal in both the tibials, but any of you would try to, how would you try to confirm that both the tibials are actually connecting at one spot and don't have 2 planes running in and connect somewhere in, like, let's say the mid-pop or the P3 segment?
The only way really,
Yeah, let's do it.
the only way to really do that would be through IVUS for confirmation purposes.
Anybody else? Any other view?
Let's say in a world you don't have IVUS, you can't afford it or something like that, you can put a buddy wire through the sheath from an antegrade. You can then either put another catheter or a snare to make sure that you grab that retrograde wire to make sure you truly are lumen to lumen there.
Awesome, great. So what we're going to do is, just for the definitive therapy, George, what's your thought process on it? Because we'll be running short on time and we have to take a quick 5-minute break if we go to the next live case. But what's your thought? Once you have all the balloons and everything in place, what's your definitive treatment strategy here?
No dilator. Yeah, so my definitive, I think what's going to happen is, so in terms of your question, I took the wire from below and I went into the anterior tibial. So I know I'm in the same channel.
Right. That's
the first thing. Second thing is I think once the drug-coated balloon, once we leave it up for 3 minutes, I'll bring it down. And if it looks good, I'm just going to Sapira from the P3 segment back to the P1 segment for sure, and then see what it looks like from there. And then depending on if it looks like there's a significant amount of calcium, I'll use a Sapira versus a drug-eluting stent. from above, because I'll tell you that proximal cap was hard, really tough.
Oh yeah, definitely. It looks very hard to get through, and especially the different techniques you had to use actually re-establishes the whole fact. Just for a final question, when you know you're going to deploy a stent in the AT and the P3 segment, and you have now a big size mismatch, deploying a Supera and let's say a coronary stent, whether it be 3.5, 4.0, 4.5, you can use a Megatron and you can expand your coronaries all the way to 5.0.
Yes.
What technique do you use actually to put the stents in? Do you go first coronary deployment, telescope your Supera in there, or you put the Supera first and telescope your coronary in there to apply the conduit? Let's start from...
So always place your Supera first from above, and then lay your coronary stents in, and you can lay them inside the Supera. You can lay one from above and one from below.
Yeah, I mean, that's a very good point, because like I was saying, nowadays you have coronary stents, especially the Megatron stent, which actually you can upsize it, the proximal end or one edge of the stent to a bigger lumen and still keep your distal end or the other end of the stent to its nominal size.
Yeah.
So that's one of the advantages we can have in these coronary stents as well, and they expand very well.
For the trainees to remember that we're talking about a balloon expandable coronary versus a self-expanding popliteal, so you have to remember the mechanics of that, and that's why George said it exactly the right way to do it.
Awesome, great. All right, so I guess we're going to keep this live case running on the side. George, we're going to take a quick 5-minute break, and before we go on to the PK, we'll try to connect with you one more time for the live pictures. All right? Thank you, everyone. You can have a quick 5-minute break.
That sounds great. And listen, what I also can do is I can show the pictures at the 3 o'clock case before we start.
Okay, that's great. I think that's a better idea. Great. Sounds good. We'll see you then at 3 o'clock. Thank you, everyone. Thank you, George.
Thank you all very much.
Excellent case. Great job.
But listen, if we could go to the slides, the case we did this morning, and let me start by saying this, that the cases that you're seeing today from me are ad hoc. So to be honest with you, until we got in there, we didn't really exactly know what we were getting until we took those initial pictures. So show them this first case. So if you remember, this is a person that had critical limb ischemia, more or less rest pain. This is the distal SFA occlusion. It was rather long. Next slide, please. It extended all the way through the popliteal. You saw the anterior tibial come off, really no TP trunk, and then you see the PT and perineal being supplied by these geniculates and surls. We were able to come from a contralateral femoral approach. In retrospect, if I would have known what we were dealing with, an integrated approach would have been nice, but that's what we had. We also accessed the posterior tibial. We did a double balloon technique, and then we were able to fenestrate the lumen, a 4.0 balloon from above, 3.0 from below. We're able to, from above, traverse the lesion through the anterior tibial, then ballooned into the anterior tibial, first and foremost, back through the popliteal and the SFA. And then what we did is from below, since we had posterior tibial access, and we had a 4.5 French or a 5.4 range sheath in, we were able to use a drug-coated balloon from the distal aspect of the TP trunk up into the SFA. And then after opening that up, and it looked really good, especially the AT TP trunk distal popliteal connection by balloon angioplasty. Go to next slide, please. We were then able to lay 2 Supera stents. We pre-dilated the popliteal and SFA with a 6.0 balloon to make sure it was adequately prepped, and then placed 2 Supera 5.5 by 150 Superas. And I just show you this picture to show I stacked it pretty well to give you that radial strength. Next slide, please. And then as you can see, this is the final result. Wow. 2 5.5, 150 Superas and 1 6.0 by 100 alluvia that we used proximally. Next slide, please. And I think you can appreciate that nice distal popliteal P3 segment into the anterior tibial, TP trunk, 3-vessel runoff. Next slide, please. Just to show us going into the foot. And then the last slide, please. And then this is your foot. You can see the actual loop of the anterior tibial and posterior tibial, straight inline flow. And I will tell you that his pulses are bounding. So that's that case.
Unbelievable case.
Now we have okay. Any comments in regards to ending that case? Because it was a lot tougher than expected.
Kumar.
George, this is Kumar. I just want to say you took a long time to do that case, so thank you.
That's the reason I need you here, Kumar. You could help me out.
George, you're a brave man to take on these cases with no upfront imaging, but that was a very challenging case, and I like the way that you managed the trifurcation. You were able not to leave anything behind there using that drug-eluting or drug-coated balloon approach and having access into both of those vessels. So that was nicely done.